It's a pleasure to be here. ECHO is a great initiative and the first of its kind for the Prader-Willi, world. And I'm really honored to be here in this international audience, with this international audience. And I'll try to do my best. So we'll, you heard the title, and I'm at Maimonides Medical Center in Brooklyn, New York. I have a couple of grants from FPWR, which I'm not going to touch upon today. I have some consultation revenue, and I do get royalties for the book that Tony just mentioned. I am going to be using some images from that book today, just so you know. So FDA is not relevant to all countries, but we might be discussing some medications here, although I'm going to try not to spend too much time on medications alone. We'll talk about just a basic overview of the genetic causes of PWS, which I'm assuming everyone is familiar with already. We'll talk about what could be some of the neurobiological and neurostructural causes. Then we'll talk about the challenges and the limitations of current treatment. And then a novel, somewhat novel, especially in the context of PWS, phenomenological model for understanding abnormal behavior and response monitoring, in particular in PWS. So something that we are probably all familiar with, and this is an example of what a primary care physician across the world should be familiar with, right? So a 12-year-old male comes in to the peds clinic, short-statured, overweight, small feet and hands, and you have the usual sort of buzzwords, right? Hypertonic, insatiable hunger, sometimes eating out of the garbage, continually preoccupied with food, aggressive, especially in the context of limiting food access. And what would the genetic finding would be. So this is a typical vignette that physicians across the world are exposed to, right? No matter where you are. But the full picture is a lot more complex. So this focus on mental health really, talks a lot about behavioral issues and beyond aggression, perhaps even looking at what underlies the aggression. So starting with the genetics, you all probably know more than me on this, so I won't touch upon it too much. This is taken from FPWR, the website. Deletion is the most common cause of the PWS critical region, the paternal 15th chromosome, and uniparental disomy is the second most common cause, followed by the methylation defect, leading to imprinting abnormality. So one in 22,000 to 25,000 live births. And it's interesting that there are other chromosomal diseases. So the one that comes to mind is 6q deletion, which basically has the same phenotype as PWS. And basically, they don't have a functioning hypothalamus. That's it. That's what's common between the two. And they have the exact same phenotype. So there's a genetic component that we'll focus on, but then there might be a purely structural aspect to it as well. So these are some of the clusters of genes that are known to be involved in PWS, right? So the MAGEL2, Schaff-Yang syndrome, sort of associated cluster in 15q, actually causes a more debilitating phenotype, which is exemplified by autism, hypertonia, but they also have hyperphagia, right? And then you add to that other aspects, right? Nectin, right? The big one with nectin is skin picking, right? So even in mouse models with nectin knockout mice, they have an increased need to groom, right? So the excessive grooming, which is very similar to skin picking. So, and there are problems with pain regulation, although nectin is not associated by itself with hyperphagia. The imprinting center defect, of course, leading to classic PWS presentation. Nectin seems to be involved with migration, nerve growth and migration, and serotonergic functioning also. SNORD 116, somewhat controversial, but has been linked with multiple aspects of PWS, and so does SNORD 115, 5-HT2C dysfunction. We'll talk, if we have some time, we'll talk about the different serotonin, different ways serotonin might be affecting PWS. So the one thing we have all agreed for since since we've been talking about PWS is that this 2-gram organelle or organ in the brain seems to be at the center of PWS, right? The hypothalamus, which is interesting. It's such an important organ, right? Most organs which are important in the human body, there are 2 of them. So one gets knocked out, the other one takes over. Hypothalamus, for example, is the only one that's coming to mind that kind of like, I guess the heart. But, there are very few such organelles, and hypothalamus is one of those problematic, fragile organelles where if it's knocked out, you're in big trouble. So, and again, those of you who treat PWS probably treat a lot of patients with, craniopharyngioma, very similar acquired PWS type symptoms. We're talking about the same issue here. Now, in PWS, additionally, and maybe it is related completely to the hypothalamus, or it's because of other aspects of PWS, there are problems with nerve migration, neurotransmitter functioning, not just with its release, but also receptor densities and the functioning itself of the receptors. So this is just a schematic that I worked on in order to sort of understand how interconnected hypothalamus is with so many other very important aspects of the brain, right? So the one that is kind of least talked about, but is extremely interesting is insula, right? It's the hidden cortex. It's kind of like in the inner part of the temporal lobe, the insular cortex, right? And studies have shown in the non-PWS population and also in the PWS population, and actually Dr. Holland's study with the functional MRI study, I believe, showed that there's a hypofunctioning of the lower cerebral areas, and insula was a big one in there. And it seems to be related to response. We'll talk about response perseveration in particular, but skin picking, impulsivity. There seems to be a higher density of the von Economo neurons, something that Dr. Janice Foster has talked about in the past. More things that need to be explored in the insula and PWS. That is sort of like a gap in the knowledge right now. The hippocampus, of course, is closely linked to the hypothalamus. Anterior cingulate cortex, again, has a strong link to repetitive behaviors. It's actually been linked to OCD, right? Although OCD, we don't see classic OCD in PWS, there's a lot of compulsivity, inflexibility, impatience. And then the orbitofrontal cortex functioning, dysfunction may lead to inattention, may be linked to confabulation. So a lot of these findings are not studied directly in PWS, but because of the hypofunctioning of the hypothalamus, which affects all of these parts, we have a combined knowledge base that can help us postulate that the hypothalamus, not singularly by itself, but because of its relationship with other aspects of the other parts of the brain, is leading to this complex neuro behavioral manifestation. The reticular activating system, extremely important for both attention and wakefulness, is also affected. So what is response perseveration? This is when I came across this, it was mostly in the context of gambling, but it felt really interesting in the PWS context, right? This is the inappropriate repetition of a particular response despite the absence or cessation of rewards. Now, this is something that I think people will relate with with the fact that, so I think the classic example that comes to mind is how patients with Prader-Willi syndrome will continuously ask for a particular caregiver, for example, or even for a doctor. So when are we going to go to Dr. Singh, right? So they're coming from Texas to New York, right? And they're talking for 6 months straight about when that trip to New York is going to happen to see Dr. Singh for 30 minutes. And they just can't stop talking about it. And, they've been told 1,000 times. So other people in which their sort of their ability to come to a homeostasis in when there is a change in the environment, if that process is intact, they'll be able to see that mom's getting upset, dad's getting upset, they're getting angry, they're raising their voice, they are getting irritated. There's so many social cues and interpersonal cues that is alerting them that, okay, I shouldn't push their button anymore, right? But folks with PWS, the need to stay on that path of repetitive behavior despite these negative responses or absence of reward, that is response perseveration. Fits well in PWS. It is closely linked to compulsivity, right? Repetitive questioning, intrusive behaviors despite negative response. And it can look like anxiety. Anxiety is a symptom. It's not a disease. People keep getting confused. And I think it's very important to talk about the fact that anxiety is a presentation which can have many different underlying causes. Is it because of their impulsivity that they're presenting this way? So that's a question that hopefully we'll be able to answer today. So in order to understand response perseveration, which is because something went wrong, we need to think about what went wrong. And the system responsible to flexibly adapt to changes in the environment is a system which is actually very well described, and that's called the response monitoring system. And I'm sure, Dr. Bedard or others who are on the call today, or Dr. Roof, they're probably a lot more familiar than me, but I found it to be fascinating to sort of like stumble upon the response monitoring literature. And it's very simple. Basically, response monitoring is our ability to maintain homeostasis, mental homeostasis, right? And in the face of uncertainty, when there is uncertainty, right, the trip to New York to see Dr. Singh is canceled, right? That is leading to extrinsic, external stimuli. Mom and dad have said that the trip is canceled. And for most people, right, if they don't have PWS, there will be a lot of extrinsic stimuli and also intrinsic stimuli. Butterflies in the stomach, I'm feeling nervous, I'm starting to sweat, starting to feel a little dizzy, I wasn't expecting this. And there's a lot of action that happens internally, both in our brain and in our body, which is giving signals to our brain through the subcortex, trying to understand the emotions, the drives, the arousal, right? Because there are more neurons in the gut, right? There's more serotonin and more neurons in the gut, and all of those symptoms, all of that stimulation is coming along with us trying to plan and change our plans, judge the situation, and effort appraisal. Very interesting, right? How much, like, what will I have to do? I really want to go to New York, right? My mom and dad have canceled this plan. How much effort is it going to take? Is it worth it for me to fight my parents at this point? Or is it okay that I'll be leaving a week later? That effort appraisal requires a lot of slow system 2 type of thinking. If you guys are familiar with Daniel Kahneman's work, system 1 versus system 2, a lot of this cortex model-based thinking is system 2, slow, planned, right? Well thought out, versus a lot of the model-free subcortical processes are a lot of system one, sort of intuitive type of decision making. And this whole thing, this whole process is response monitoring. And in all of us, most of the time, unless we're drunk or we're extremely stressed out or we're sleep deprived, and add to all of these other, you know what I mean, we've all lost the ability to do proper response monitoring. We know what that feels like. What I'm trying to say is, because of the abnormalities that we discussed in the cortex, and of course the hypothalamus, which is processing so much of this information coming from all over the body, our patients with PWS have a lot of trouble with response monitoring. And this is leading to response perseveration, that presentation of anxiousness, impulsive aggression, and getting stuck. So to give you an example, when there's uncertainty, this process of response monitoring is so difficult, so effortful for folks with PWS, that they'd much rather just stay in the local. So I'll give you an example from one of my patients. One of my patients, he enjoys taking long walks with his mom. But at the end of this long walk, just before they enter the door, he gets into a fight with mom, starts yelling, screaming every time without fail. So what I asked them to do is to start delaying the entrance and then taking the back door. It stopped. The shouting, screaming matches stopped just because that, so an example of how for that patient, it's easier to shout and scream than to try to adapt and not scream this time. They're getting all these social cues, which is like, okay, this is time for screaming. This is what I've been doing all this while. I'm not going to stop doing that. So unless we kind of break that loop. So now I'm not sure, I listed skin rectal excoriation. We can even we can even mention hyperphagia here, but I don't think that it's as simple as explaining all of those, complex things. But I do think the response perseveration, the anxiousness, impulsive aggression, a lot of the repetitive behaviors, confabulation, getting stuck can be explained through this maladaptation in response monitoring. And the bottom line is that our patients with PWS are impulsive, right? They have a tendency to engage in rash, ill-considered action, response to intense negative emotions. And, we know not just in PWS, PWS do tend to have low volumes in the prefrontal cortex. The kind of aggression that we see in PWS is reactive. It's not planned or proactive. Which also goes back to show that there are difficulties with response monitoring. So I won't take too long. I think it's a little bit of a digression, but folks probably know that psychosis in PWS is common. It can be classified as something called cycloid psychosis. We've published on this, but this is, at this point, a well-known phenomenon in PWS. It's sort of an affective psychosis, which is accompanied by a confused state. So I was confused state, catatonic behaviors, and they respond really well to low doses of antipsychotics relatively quickly. Some people also use lithium. I don't use as much lithium, but that's also been shown to be very effective. So I was thinking about why, what puts them at such high risk, to the point that the 15th chromosome has been an area of interest for other psychiatrists to explore, the genetic causes of schizophrenia. So why is it? What's different about PWS? So this is a completely theoretical slide, right? This is, so these two lines, the green line and the blue line, right? They reflect receptor densities, 5-HT2C and 5-HT2A. Now, we know that dopamine is linked with psychosis, right? Everybody knows that. I'm assuming that everyone knows that. Okay, so 5-HT2C, 5-HT2A and 5-HT2C are both linked to dopamine, right? 2A activates dopamine, increases dopamine activity. 2C reduces dopamine activity, right? This is in the normal brain. This has already been studied, right? We know that 2C activity is reduced in folks with PWS. So the calming part of 5-HT2C, right, which keeps dopamine in check, is low to begin with. Around the teenagers, in everybody, right, normal subjects, non-PWS subjects, this divide between 2A and 2C hits a critical point. And if you are predisposed to psychosis, we all know what happens, right? Adolescence is high risk for the first break of psychosis. Now, that gap is presumably even wider in PWS. That's what this is highlighting, which means that there might be an increased risk for psychosis, independent of, and I don't know what the hypothalamus has to do with it, but it's possible that because of the migration issues and receptor density issues that are part of PWS, we are seeing an increased differential during this critical time period in the teenagers, which is the high risk part for cycloid psychosis. So this was just like, this is completely theoretical. This aspect, although we know that HT3C densities are low in PWS, we haven't been able to prove this aspect. This is a theoretical slide completely. We know that this might be a mechanistic, explanation. So I'm not going to spend too much time talking about the medications today. I can always go back to the slides if there are particular answers. I do think that we need to focus we need to focus on fixing this dopamine and serotonin imbalance in PWS, or bypassing it completely, right? So a lot of the medicines that are of interest to me, right, like the alpha-2 agonists, they kind of bypass the monoamine systems and kind of reduce the risk for psychosis. Well, at least does not cause psychosis, which is helpful. So in summary, there's this dysfunction waterfall, right? The genetics leading to neurobiological problems, ultimately leading to behavioral manifestations that is complex. But perhaps today's talk helped understand this a little bit better. This is my team. We've got a wonderful research division that I'm part of. We see a lot of patients with PWS. It's a lot of fun. Thank you for your attention. Just a quick coverage of what we're doing right now. This is my book. It does not talk about hyperphagia. So, but other than hyperphagia, it covers the other aspects of PWS. And thank you again for inviting me. I'm looking forward to a good discussion.